We are reporting this information to you from the DeBakey Institute for Cardiovascular Education and Training in Houston, Texas. Now let's talk a little bit more about integration as far as procedural and periprocedural tests that can prevent not only access site complications, but many other complications. The important aspect is to use all the modalities that are available to us, such as CT scans, MRIs, ultrasound, and so on. Current technologies are offering us the opportunity to integrate all those modalities and make it easier for us to obtain adequate imaging during the procedure and also make preparations for the procedure, as well as reducing the risk of radiation during the procedure. I think that's a very important aspect to take into consideration. We all agree, as far as all the specialties are concerned, that access should be obtained on routine basis with the ultrasound guidance. That adds safety and reliability and lowers the risk of any complications that could occur during the procedure. Typically, we use micropuncture kit for access, obtain proper imaging in proper views, and it's also important to use a digital subtractive imaging for better definition of lesions, severity of the disease, and also to gain access in certain instances when we think this is the best opportunity. The latest technology has offered us additional benefits such as rotational angiography for 3D imaging and Dyna-CT that give us an opportunity for automatic reconstruction in a very short period of time with rotational angiogram. When we use Dyna-CT, we use fewer imaging and reduce the patient and also the operator radiation dose. It is particularly useful for TAVI, mitral repair, but also for thoracic repair, as well as carotid interventions and lower extremity interventions. Overlay with 3D volumes and contours or points of interest with the live fluoro images is also extremely helpful and very beneficial during interventional procedure. We can also dramatically reduce the radiation dose with this type of modalities and obtain good quality imaging with minimal radiation dose and achieve better definition as far as the anatomy, particularly in patients that have dose-sensitive issues such as chronic renal failure or contrast allergy. There are a variety of modality technologies available, and the oldest one that is routinely used is iodinated agents, which offer us excellent imaging opportunities. However, there are certain side effects with it that we'll discuss briefly. Here is an image on the left side of iliac angiogram in a patient with Leriche syndrome or CTO of the abdominal aorta with excellent imaging, as we can see, as well as collaterals and post-intervention imaging. Now, in certain subset of patients, there are contraindications, either absolute or relative contraindications to use iodinated contrast. Of course, allergic reaction is one of the most common one, but not infrequently renal toxicity is another serious issue, not only in patients with borderline, but also patients with advanced renal insufficiency. And also there is a cost issue involved with it as well. CO2 as a contrast medium has been introduced to address and resolve those issues in patients that have a contraindication to the use of iodinated agents. It's a natural substance that is soluble in blood, that is very inexpensive, and it's easily removed via lungs and is readily available. It's not nephrotoxic, and therefore it can be used in patients with chronic renal failure and obviously in patients with iodine allergy. However, this particular substance cannot be administered with the standard, so we call power injectors, but it has to be administered with hand injectors, and therefore the resolution as far as imaging is concerned might not be as good as with iodinated contrast. It can cause certain amount of pain, particularly in abdominal circulation, but also in the lower extremity circulation. But also it offers less quality image than iodinated agents. Now, what is extremely important, that CO2 can be only used below the diaphragm, in the abdomen, pelvis, and lower extremities, and it cannot be and should not be used in the thoracic aorta or coronary arteries or cerebrovascular circulation. More recently, we have devices that deliver CO2 at a very low risk of air interaction or embolization, and that offers us an easier way to obtain good quality CO2 angiography. As we can see here in this particular abdominal and iliac CO2 angiogram with excellent imaging quality. However, in certain instances, such as in this particular image of a patient that is relatively obese, that has a very active intestinal motility, and patient that also is not holding a breath, where image is not as clear and as defined as it is with iodinated contrast agent. Another scenario where we have iodinated contrast agent used for celiac angiogram, and in comparison, we can see CO2 angiogram with excellent imaging, excellent details. Now, this is obtained in a patient that is holding his breath, and there is no interaction with intestinal motility. So in most of the occasions, the imaging is adequate, but in certain scenarios, it might be suboptimal. Now, what about other locations as far as imaging is concerned? One is aortic arch and carotid angiography. How to obtain the optimal angiogram in cerebrovascular circulation? Typically, we will first obtain arch angiogram to determine whether the patient has any complexities as far as anatomy is concerned, and we'll see shortly what that means. Typically, the arch angiogram is obtained with a 5 French pigtail catheter in an angled 45-degree LAO views, and typically we will give about 20 cc's of contrast per second, of a total of 40 cc's, which will clearly define the origin of the cerebrovascular anatomy. What is again very important is to use other modalities that have been used previously for imaging purposes, such as CT angiograms or MRI rotational imaging that can also very clearly define the anatomy, and we can make a decision on the basis of those studies whether additional angiography such as arch angiogram is needed, or if the interventional procedure is of high risk to the patient if it is done in very complex anatomy, such as, let's say, we could do a carotid artery stenting, like this patient has a severe internal carotid artery stenosis via femoral approach, but if we have a very complex arch, it might be better to do a TCAR or direct access to the carotid circulation and avoid complexities and risk of embolization of the atheromatous material during the intervention using a femoral approach. So here we have images of a type A arch, which is a normal anatomy commonly seen in normal individuals, but occasionally we see very elongated arch, such as type B, or even worse, type C arch, that would add complexity as far as imaging is concerned, and also intervention of any kind. So for simple anatomy, non-complex anatomy where we do not have elongated arch, we can use a simple angiographic equipment, as we can see here, a headhunter type of catheters for cannulating the cerebral vessels and obtain angiograms. But once we have a bovine arch, or if we have a very complex anatomy as far as arch is concerned, then we have to use more complex reverse curves such as VTEC catheter to gain proper access and avoid complications in this type of a scenario. Another important aspect is when we are obtaining carotid angiograms is to separate the external carotid artery from the internal carotid artery, and this is typically done in lateral or oblique views. And also, as we can see here, we have to have a marker of some kind so we can measure the diameter of the vessels proximally and distally to determine what size balloon and what size of stents are needed. Of course, on routine basis, we have to know what the intracranial circulation looks like, and that should be done on a routine basis for anybody that has suspected cerebrovascular disease. And this is obtained in a lateral view, as we can see in the first image, and also in the AP view, not only to see additional anatomy that is not seen in the lateral view, but also to see the contralateral circulation. So, Dr. Shaw, do you have any comments so far as what we have presented, particularly how frequently do you use CO2 and how useful is this in your practice? And also if you have any other comments related to cerebrovascular angiography.
I do use CO2 quite frequently in my practice. I know it's an old tool, and I think it's one that should be utilized particularly in patients with renal insufficiency. And there's many different dose adjustments to the imaging that can be used to optimize your CO2 quality. And CO2 can also show things that we don't often see in regular DSA angiography with contrast, such as improvement of collaterals. You can see collaterals with CO2 that you don't see with regular iodinated contrast. The other day I was able to do an intervention in a morbidly obese woman with a creatinine of 3.5 and intervene in her lower extremity using CO2 and only 9 cc's of contrast. So she did very well with that, and incidentally, the contrast demonstrated an AV fistula with the CO2 that was not confirmed by the DSA imaging. So CO2 certainly used correctly has a lot of advantages. So I do think it should be part of the armamentarium for the endovascular specialist. And I would agree with you that transcarotid stenting is gaining a role, particularly in patients with challenging or hostile arch anatomy. So we should definitely monitor that for outcomes going forward.
Excellent. Thank you very much. So the next aspect as far as imaging is concerned is how to obtain optimal lower extremity imaging. And we can see here what is important again is to identify the anatomy and lesions clearly. And we can see in image A that we are obtaining an oblique view in this patient with left common and left superficial femoral artery lesion. We're separating the profunda femoris from the SFA to identify the lesion. If you obtain an image in the AP view, you might miss the severity of the disease or the lesion altogether. So that's very, very important. And then in the image B, we can see interventional procedure, image C and image D, the final result. Again, obtaining the view in the most appropriate view that will clearly define the lesion. Now, what we can see here is what we use on routine basis is so-called Bolus chase setting, which is angiographic imaging, identifying the anatomy, starting in the lower extremity from the external iliac artery, going all the way down to the distal vessels in the foot. That will, in one image, clearly define the anatomy and address the problem that exists and guide us to the most appropriate mode of intervention. Here we can see on the left lower extremity, again, a Bolus chase image showing CTO in the distal portion of the SFA and popliteal artery with abundant collateral work. Now, for adequate imaging during the intervention, we have to define the anatomy clearly, and we will use a still frame, as you can see here on the right-hand side, to identify if this particular lesion is the most appropriate for intervention or surgery. In this particular patient, we can see very abundant collateral network. However, this patient had significant symptoms and the intervention was performed. Below the knee, we can see again imaging and importance of imaging in defining the lesion, like here in the distal popliteal artery and tibioperoneal trunk, before on the left-hand side and after the intervention. Again, magnifying the area of interest is extremely important during the intervention. And finally, again, the benefit of CO2 angiography in a certain subset of patients with lower extremity disease, such as patients with diabetes mellitus that are more prone to renal toxicity with iodinated agents, patients with chronic renal failure, and obviously patients with iodine allergy. We can see that we can obtain perfect imaging technique using CO2. What is very important is when you are obtaining a CO2 angiography in the lower extremity, it is much better to inject it through a larger catheter, such a sheath, and less beneficial to inject it through the end-hole catheter or a very small catheter, because you will have less than optimal imaging with this particular approach. So, in conclusion, as far as angiography is concerned, significant progress has been made in imaging in the last few decades for better, faster, and more effective patient care at the lowest possible radiation dose. Some of the currently performed procedures would be unthinkable without all the advances that we have achieved in the last few decades as far as imaging is concerned. However, before proceeding with angiography, one should consider the most appropriate access, the most appropriate equipment, contrast type, and amount used to achieve optimal imaging, and also to take into consideration patient safety and also operator safety. So I believe that the next frontier will be integration of robotics and imaging technology to achieve good quality imaging and offer better patient care. So Dr. Shaw, I would like to ask you a very important aspect because you have been currently elected as Secretary of the International Society of Endovascular Specialists. And I would like to hear from you, what are your goals, what are your objectives as far as the society is concerned, and also the role of women and how we should approach to attract more women to this field and to our society.
Well, we've set an aggressive goals and objectives for the society. We are definitely going to expand the membership, which does include a multidisciplinary group of specialists such as interventional radiology, cardiology, and vascular surgery, and others. We were even speaking about engineers and integrating the knowledge from the engineers with the ingenuity of the practicing physicians and marrying those to facilitate innovation and progress in our specialties. Additionally, we've revamped the website, and so that we will have specific topics on the website, how I do it, for example, challenging cases, a network to ask questions of the experts, and other resources that will only be available to members. So we'll be reaching out to our colleagues and expanding the membership to also candidate members who are trainees, medical students, allied health professionals, and we will be also engaging the young surgeons, those who've been out under 10 years in practice. We want this to be an international effort. We want an exchange of ideas across the globe, because there are some techniques and devices that are available internationally that have not yet been available in the United States, and we want to draw from that. We're going to strengthen our chapters, reaching out to our ambassadors who are champions for our society in these countries. As far as women constitute over 50% of the medical student class, and there are going to be more women interested in becoming vascular surgeons or vascular interventionalists. And we're going to try to increase awareness amongst those women that it is safe to utilize radiation when you're properly protected, and that should not be a deterrent in entering our field.
Excellent. Thank you very much for this information. Now, before we complete this program, I think you will agree we are greatly appreciative to Dr. Alan Lumsden in organizing this symposium, which I think was a tremendous success. Maybe you can mention in a few words, what is your personal impression about this hands-on program that we have just completed at Methodist Hospital?
So this is really incredible, and it's been fabulous to be a part of this. I'm very honored to be part of the faculty, and I was very grateful that Dr. Lumsden included me. It's very unique. It's different from any symposia that I've ever worked on. We were able to be hands-on. Cadaver models, there were simulation models. We were able to work closely with the specialists from each individual company that has their devices available to us. We had devices that were really just released, such as the Gore new delivery system for the thoracic stent graft. We were able to utilize that in the lab. And so I think that this was very special and very unique. We will continue to do this, and we'll continue to expand and improve the education to improve patient care, which is our ultimate goal.
Thank you very much. It's a special pleasure to have you here. Yeah. Welcome to the International Society of the Endovascular Specialists as our secretary, and I wish you all the best. Thank you very much.